Okay, well, we will slowly get started. We know there's going to be a bunch of other folks who are going to be joining us, but in the respect of time, we'll get through some of the admin stuff before we get into that. So that should be helpful for those people who are just logging on now. So welcome to those of you who are here now. I'd like to start with our land acknowledgement, and then we will move forward. So Lifemark Health Group team acknowledges that our work spans many territories and treaty areas, and we are grateful for the traditional knowledge keepers and elders who are with us today, those who've gone before us, and the youth that inspire us. We recognize the land and the benefit it provides all of us, and we invite you to reflect on the past and present history in each of your particular geographic areas, and for each of us to think about what we can do towards reconciliation. So again, with a little bit of just administration, your cameras and microphones will be muted except for the speakers today. This session is being recorded. You need to know that. If you're not comfortable being part of it, then we just wanted to let you know from the beginning it's being recorded. And Uma, can you confirm that you can see that it's being recorded?
Yes.
Okay, excellent. So again, you're going to see if you can go into your toolbar. For some of you, it's going to be on the top of your screen. For some of you, it's going to be on the bottom. There's a couple of options. One is a chat option, and one that you'll see is a Q&A box. So I'd recommend you open the Q&A. We will be answering. We have some lovely folks, Natalie and Krista will be as well, answering as we go along. So open up the Q&A. That's where we will be answering those questions. Of course, we can't provide individual recommendations, and this information is for educational purposes. Everybody is individual, and you need to take the information that you feel is pertinent to you, and certainly reach out with further information. There's resources that we will give you at the end if you want some more individual or specific information or an assessment or want to seek some services. And again, as our panelists are physiotherapists, and we are bound by our scope of practice, and as such will not be providing any advice as it relates to medication, medication management, any medication assistance, reconciliation, or any advice around medication at all. Okay, so just gonna check. Perfect. Now, I'm going to introduce our awesome speakers, as we have some very special guests here that you will know are extremely knowledgeable in this area. We're going to start with Uma. So Uma graduated from the University of Toronto with a Bachelor of Science in Physiotherapy in 2003, and then completed the Doctor of Physiotherapy at the Boston University in 2010. Uma began treating clients with pelvic floor dysfunction secondary to oncological intervention while working in New York at the Memorial Sloan Kettering Cancer Center. Since relocating to Toronto, Uma has dedicated her efforts to treating women and men with pelvic floor dysfunction. She currently practices at Lifemark Leslie and Shepherd in North York and coordinates the pelvic health curriculum as an adjunct lecturer for the University of Toronto Physiotherapy Department. So along with Uma is Alana. Alana-Devlin obtained her Bachelor of Medical Rehabilitation in Physiotherapy from the University of Manitoba in 1996. She became a certified manipulative therapist in 2002 and began to pursue further advanced education in her passion for women's health. She has engaged in advanced training throughout Canada and the US, and in 2018 and 2019, she successfully obtained the Certificate of Achievement in Pregnancy, Postpartum Physiotherapy, and the Certificate of Achievement in Pelvic Physical Therapy through the American Physiotherapy Association. Alana completed her doctoral degree in physical therapy in the summer of 2021. She is proud to be an instructor and teaching assistant and working alongside gynecological and urogynecological health professionals. So some lovely and amazing resources here for all of us to learn from today. And, we came together today. I think this is a very fitting quote. I think when we're younger, we think of a couple things about getting older and menopause. Getting older, we think, oh, we're going to get wrinkles, and menopause, we're pretty excited to not have to have a period every month. And there's so much misconception about menopausal symptoms and, things that, oh, it's hot flashes and night sweats. It's short-lived and it's trivial. And there is so much more to this, and people are just starting to, I think, understand. And it's certainly education and information that a lot of people don't really know or don't know well. So, we thought that this was an absolute great opportunity to bring people together and be able to share this information. And the more you know, the more you can deal with the things that you're dealing with, maybe feel a little less crazy as you get some of these symptoms, and know that how much of this is normal, and also know that there's a lot of things that you can do. So we're going to set it up in certainly more of a question type scenario. Again, if you have specific questions, certainly that you want answered, you can throw them in the Q&A section, and we'll try to get to them. But let's start with some of the general things. So the first question that we want to put out is, what is menopause and perimenopause, and how do I know if I'm in it?
Have to unmute myself if I'm going to answer. That's how I know I'm in perimenopause. But so the first thing is this whole time of life should really be considered more of a stage of life that we all go through. I mean, you have two options. You're going to either go through the stage, or you're not going to go through it because you're not going to be on this planet anymore. So just like, we've normalized in some ways, it can get a bit better, but the menstrual cycle, and we anticipate we're going to have a menstrual cycle, and we anticipate that there's going to be changes in pregnancy, and in some ways that's celebrated. In terms of menopause and perimenopause, until recently, it's kind of been this big, vast black hole of we don't know what the hell is going on. So I have to say that it's really encouraging in women's health when you are living in this world. There is a lot more research that is going on now. A lot of it is that historically women have been we're bad research subjects, to be quite honest. If you do research, the easiest way to do research is you need two of the exact same type of groups of people to compare, and you do something to one and you see if something changes. So with women, we're hard. Did you have a vaginal delivery? Did you have a cesarean section? Where are you in your menstrual cycle? Are you menopausal? Are you perimenopausal? Like, there's so many variables. So that's why we are finally recognizing that we are 50% of the population, and we have to know more about this. So yeah, lots more research. So I want people to feel encouraged, because I sure am, being around this age. So one big thing is, how do we know if we're in it? So a lot of it is just understanding kind of the phases. So people will start seeing menopausal changes, or perimenopausal, peri is just around the time of menopause, changes early. Like, often people will see changes in their early 40s, and they'll start to notice, just slight changes, nothing that's going to really be earth-shattering for most people. But really, it's where you'll kind of see your very early perimenopausal symptoms, like you could, more difficulty sleeping. You might wake up occasionally and have those night sweats. Maybe some of your menstrual cycle, it's changing. So whether you're getting, a heavier flow, maybe a bit of a lighter flow, all of a sudden your cycles are getting longer or shorter. But I mean, these are early changes that happen. Maybe it might be that when you're working out, you notice you're having a harder time adapting or recovering after a workout. So maybe those are some of the things that we know change even in our early 40s. For some people. So you may kind of see that. So that's really kind of very early perimenopausal changes. We also know that this whole perimenopausal time can span for a lot of people for over a decade. So this is not just a little window of time that females are in. It's a matter of many years. And for some people, they go through it barely noticing anything. And for some people, it is really life altering. So you really want to make sure you're, having issues addressed if you're having problems. So after you go through, and everybody's a bit different, but these very early, kind of changes that you may or may not notice, then you kind of enter what's called this early menopausal transition. So that's really where now you definitely notice your cycles are changing. You're maybe getting some more cycle irregularity. And you're looking for either your cycle getting 7 days longer or 7 days shorter. Like there's some change that's happening. And then you go into more of a late menopausal transition. So a late menopausal transition starts when it's kind of like you've missed your first kind of like period. So you're having like this extended 60 days, like you're skipping a month basically. So you're having about 60 days where you're not having any bleed. And then so that's kind of like that can last for a few years. And then you get into what's called late perimenopause. So late perimenopause is when you've missed a number of periods, but it hasn't yet been a year, because the actual definition of menopause is when it happens in a day. It's like the click of a calendar and now you're menopausal. So when you have not experienced a bleed, a period for 12 full calendar months on that, that the next day of that next month, you are then officially menopausal. So a lot of people are actually looking forward to this time of life because there's actually some freedoms that come along with it as well. So often it's like they won't have a bleed for 4 months or 8 months or 10 months. They're like, yeah, okay, I think I'm in the clear. And then all of a sudden it's like, they get one. And I hate it because I'm like, your clock just started over. Like now you're at 0 again, and you're in that late menopausal transition again. So that's really, it's like menopause. You are menopausal, you're considered menopausal, and you're like that for the rest of your life. There is no post-menopause. Post-menopause is when you're then dead. So it's like you're menopausal once you go through that transition for your life. So, and that really does then happen. So, and even a lot of, which we'll talk about a lot later, it really has to do with like, we want to hear about people's symptoms. A lot of people are going for all these crazy tests and blood tests, and a lot of the really, really good evidence-based medicine is really showing now. It's like we really need to be listening to women's symptoms and empowering them with what they can do with those symptoms to change, and to be able to know that this change of life is coming and our physiology is a little bit changing. Excellent. Wonderful. What do I do? What can I do to change that? So that is, I think, that's what menopause and perimenopause are really about.
Great. Thank you so much for clarifying that. And I think there is a lot of confusion, right? Menopause, oh, I'm postmenopausal, to try to identify where you fit on that spectrum, but more specifically to know you may still be bleeding and having a regular period and still be in perimenopause. Is that true?
Oh, absolutely. Yeah.
Yes.
You can still have menopausal, like you can still have those perimenopause when a lot of women are in their, late 30s, early 40s, they're still having very regular 28-day, 32-day cycles, whatever it is, but they're still noticing there's just these changes that are happening. Yeah.
Right. And the changes can be subtle. So, what kind of changes can we anticipate might happen during that perimenopause to the menopause period in there? What sorts of things are we looking at potentially happening?
Yeah, well, that's definitely the next thing what we want to talk about. So just to kind of reiterate what Alana said, but I think it's worthwhile to repeat it, is that we are looking at potentially over a decade of time where things can kind of go a bit wonky, right? So what also I kind of wanted to bring up is that if we're talking about a decade of time, we're actually, traditionally we kind of think of, perimenopause and menopause as 50s, 60s, right? This isn't like they're old women problems, right? But it's not. We're actually kind of talking about late 30s and 40s, which ironically in our generation kind of blends in with childbearing years too, because people are having babies later on in life too. So you're kind of getting this blending of sort of postpartum kind of going into perimenopause, and that's kind of confusing for people. So that probably does apply to a lot of our audience today, so that we can kind of touch upon a little bit later. But if we're really going to talk about perimenopause and menopause, which is obviously what our topic is today, we have our commonly recognized symptoms like the hot flashes and the night sweats and, the mood changes and fluctuations. And of course, we do have our more notable marker, the one that comes every single month. And of course, Alana kind of touched on this again. You might have shorter periods, lighter periods, heavier periods, longer periods, irregular periods, and possibly regular periods. That also happens too. And then we kind of have our unicorn women who just kind of waltz into menopause and their periods kind of stop one day and then they kind of ride off into the sunset of menopause in a beautiful sunset. And, you know, we envy these women, but they do exist as well. And so we kind of have everything kind of in between. Now, there are symptoms that we don't necessarily recognize as readily, and they are subtle changes, but these can include things like heart palpitations, sleep disturbances, anxiety, hair loss, joint aches and pains, mood fluctuations, changes in libido, vaginal dryness, on and on and on. I think that there was a list I saw somewhere that had like 50 different symptoms. So really, anything and everything, it seems, could be attributed to perimenopause. And, you know, if you're having symptoms and it's really significant and impacting your life to a certain degree, you should talk to your healthcare practitioner about it, because if it's really concerning and you're not really sure what's going on, then it's worth that conversation, or to reach out to somebody who can kind of guide you through kind of what's going on and also possibly management strategies as well. Now, if we're going to talk about systemically what's going on with our bodies, we really need to start by understanding what the role that estrogen does play in our bodies. And estrogen, as we know, is a hormone, and it is responsible for regulation of multiple systems. And of course, the most obvious one is your menstrual cycle, but it also regulates our cardiovascular system, our neurological system, our gastrointestinal system. It's part of the endocrine system, musculoskeletal system, and on and on and on. So obviously, if you have something that is a huge part of regulation of all of these systems, you're probably going to see some symptoms or impacts to the symptoms that this hormone is regulating. So to kind of talk a little bit about some of these individual systems, with the cardiovascular system, estrogen actually plays a role in breaking down and metabolizing cholesterol. So if we are depleting the levels of estrogen in our bodies, we're likely going to increase the risk of cardiovascular disease. In the GI system, estrogen is part of motility and digestion, and can, with depletion, slow down all of these processes, leading potentially to constipation. With the endocrine system is made up of all of the glands and organs that are responsible for hormone production. And of course, if estrogen is also a hormone, but it also plays a role in the regulation of all other hormones, then of course we're going to get a whole bunch of other really interesting symptoms, things like how we uptake stress hormones into our bodies, and that can impact the level of anxiety and depression that we might be feeling, our overall levels of energy. Sometimes you can kind of get this just like overwhelming fatigue that just kind of comes up out of nowhere. It can also suppress the immune system. And of course, the thyroid is also a gland that produces hormones. So we can kind of open up the potential for there to be hormone fluctuations, or thyroid fluctuations as well. As far as the neurological system goes, that's where our brain fog and memory issues come from. So when you're having word finding difficulty, which happens to me all the time, chalk that one up to perimenopause too, right? That's also partly what's going on there too. The other fun stuff that happens is that our bodies kind of start to change. The composition of our bodies change. The elasticity of our skin, where we pack our fat, it starts to kind of get packed up into the middle section of our bodies around the internal organs. And so we may not notice necessarily a change on your scale, but we definitely know that our clothes start to fit a little different. So that's going to be something that will also be a part of what we'll start to notice in that perimenopause to menopause stage. Now, of course, being physical therapists, Alana and I are very interested in these changes that happen on the musculoskeletal system. That's kind of our wheelhouse, right? So when we start to have a depletion of estrogen, what happens on the muscle level is that we start to see a decrease in lean muscle mass. And then on the level of tendons and ligaments, we start to see this increase in stiffness. And so muscles are usually attached to tendons. And so if you have a muscle that is no longer able to generate power or produce endurance, and it's attached to something that doesn't have an elasticity, then we're going to open up the door for potential muscular injury. And particularly the joints that are most susceptible to these types of injuries are the ones that have a lot of tendons, things like the joints and the hips. So these joints actually move through multiple planes and are very susceptible to this type of injury. So this is where you kind of see all those frozen shoulders kind of come about. Now, on the level of bones, what estrogen does is it doesn't necessarily change the resorption of the bone, but it changes the building of the bone. So this can lead to a diminishing of bone mass and bone density, and of course lead to an increased risk of osteoporosis. And all the combination of all of those things, if we have weakening muscles, and bone density decreases, we're also probably going to have an increased risk of balance challenges and fall risk, which are obviously things that we are here to help prevent and try to help avoid and have strategies that we can kind of work around. Now, all of this stuff sounds super scary and really dire. And as I was kind of putting it together, it was like really coming at me like, wow, these are like a lot of symptoms and a lot of different systems that are impacted. But what's important to know is not everything is going to happen to everybody. And there are many other reasons why these symptoms can occur as well. So let's say, for instance, someone is a sedentary person who doesn't eat well, doesn't exercise, you're already at cardiovascular disease risk. So taking away estrogen isn't going to make that risk any better. It's probably going to increase the risk even further. So there are things that you may already sort of be working with, and that estrogen factor will just kind of elevate those risks and not necessarily be the causative. So having understood all of those things, what we do want to talk about today is, first, we have to empower you with what to expect and what is potentially going to be influenced by the lack of estrogen in our bodies, but more importantly, that what we can do about it and how to maximize our window of opportunity so that we can kind of cruise into these transitions as opposed to waiting for it to happen to us. And so that's kind of what we're going to be getting into a little bit later in our talk.
Yeah, absolutely. And fortunately, we will experience this all on a very individual basis, but what we want to do is not scare you, but really empower you and tell you some of the things. So can we just talk a little bit about what we should be changing in the way we exercise, or if we're not exercisers, what should we be starting to do and consider in this very specific time to help combat, prevent, or minimize the effects of some of these changes that you were just speaking about?
Yeah, that was great. That was like a fantastic summary, and it very comprehensive. And exactly, I think the biggest thing is, this shouldn't be scary. I mean, because it's being very well addressed and researched, and there is tons of help now. But we just need to you need to know, like, we know that we're going to have this slow decline of estrogen. Testosterone does not decline as much. It's like men don't go through this menopause till much later. So another thing they got going for them. But we know we can do things. Like, we know what we're losing and we know what we have to change in order to make up for that. So in terms of workouts, I love talking about this because it's kind of, a lot of, different things that people kind of, you'll have all these women, the thing that are finding the things don't work anymore. The stuff that they used to do to lose the belly fat or the body weight, it's just not working. They'll go through these, I spend an hour on the treadmill. I am doing hard cardio. I'm going for hour-long runs and I'm eating 900 calories a day and I just can't get rid of it. But that doesn't work in menopause, because menopause, like Uma mentioned, a big thing is how estrogen supports our stress response or our cortisol levels. So we're finding you have a lot better, insulin tolerance in terms of like managing your blood sugars and improving your overall muscle mass and not spiking your cortisol levels. Because what cortisol does is it sends you into a fight or flight response. So estrogen really helps bring us out of that. So when we don't have the estrogen as high to bring us out of that, we don't want to be in that for such a sustained time. So in terms of cardio, I still want people to work out hard. So one is high intensity interval training. So that is hard, high intensity. You are going full force as hard as you can. And usually it's anywhere, depends on what you read. High intensity, you want to keep up an intensity somewhere between 20, max 60 seconds. So most people say it's a kind of between that 20 to 40 second mark. And also in our brain, we can do anything for 30 seconds. I mean, you can do anything for 30 seconds until you try it really hard. Like this is where you are working all out, and then you want a recovery because you're stressing your system, you're working hard, you're sending your body into, like, is this a fight or flight situation? And then you're recovering. So your cortisol levels aren't spiking. And that is helping tons with body composition, because it's not the tire we see here from the outside. It's that you're actually getting, it's called visceral fat, the fat that accumulates around your organs. And that's what poses the health risk. And that's what increases our risk of all of our cardiovascular diseases, and which becomes a huge thing for women that we don't talk about. It's cardiovascular disease is something for men. We don't talk about it as women. Once you're menopausal, it is a huge risk for you. It becomes one of the number one risks for mortality for women. So high intensity interval training, you want to go hard 20 to 40 seconds, recover, then go hard again 20 to 40. I mean, and you can do that for 20, 30 minutes. Like, get a good workout, get a good sweat on. I'm not saying to go easy whatsoever. And you want to probably do that 2 to 4 times a week, because you want to maintain your cardiovascular fitness. So it really has been shown to help a ton with that, especially when they've done studies looking at people who are, menopausal or even perimenopausal. One more thing is for people who have not yet become menopausal women can still change this, but you really can make really good lasting benefits if you make some of these changes during those perimenopausal years, like kind of the 3 to 4 years prior to going into menopause. That's where you really want to try and change your body composition. So that's it. So that in terms of like a lot of cardio, it's that high intensity interval training. It's even if people you can run all out for 30 seconds, recover for 2 minutes, run all out for 30 seconds, recover. Anyway, enough about that. Second one is, so we're talking about bone density, and we did an amazing job talking about how, estrogen affects overall your bone density, and we know that can decrease. So we need to make sure we're maintaining our bone density. We all have heard weight-bearing exercises, but a lot of people will be like, I'm a runner. Running is absolutely a weight-bearing exercise, but bone, it's called like your trabecular bone, the kind of support structures in your bone are basically formed in all these different directions. So your bone is strong throughout every kind of force of movement or line of stress. So you also want to be exercising in different lines of stress. So people who are runners, I want you to start doing ski jumpers side to side, do some side to side movements. So plyometrics are like explosive movements. There's quick explosive movements. So I was just showing somebody the other day, even, it doesn't all just have to be your legs. I mean, bone density goes through everything. So even doing a push up against a wall, pushing off, then coming back and catching yourself, pushing off, coming back, taking a ball and doing ball slams on the floor. That's a big thing. Doing ball slams on a wall. So those are still considered plyometric exercises. So just move your body as many ways and in as many different directions as possible so that we can get you building that bone density in all those different directions. So that's a big thing. And then in terms of weights, so this is the other thing that I think we all have wrong is we're like, okay, I'm getting older, so I probably should, I should take my weights down, and I should probably, I'm going to scale it back to my 3 or 4 pound weights, and I'm going to do high reps of 3 or 4 pound weights. But we just heard how estrogen really affects our ability to maintain our lean muscle mass. So we have to really work on that much harder so we can counter the effects that we know we're declining in estrogen slowly. So we got to do the things that are going to make that up. So one is you need to lift heavy, but not lift heavy and hurt yourself. If you've never lifted heavy, I really encourage you to go see somebody who can, guide you in how to lift, how to breathe properly through it, how you're not, I don't want to see people lifting and doing like holding your breath, because that's a whole other thing we can talk about. That was in our last webinar on pelvic floor health, because I don't want people having all of these other problems. But really, you want to lift heavy weights. And when I say that, you want to get to kind of like, you can do maybe 4 to 6 repetitions of an exercise without losing your form. But like at the end of 6, you're like, all right, I'm happy I'm taking a break for a second. Like, so you want to be doing like lifting heavy. And when you're lifting heavy, you can usually do less repetitions of a certain exercise. So that's really the big thing, is like, so I always tell people it's the 3 ones we know for sure that have been researched are high intensity interval training to maintain your cardiovascular status, lift heavy, which is also good for bone density, but really especially for maintaining that muscle mass. And also, like, the other one I didn't mention that you did mention, Uma, was balance. So getting some, Tai Chi has been awesome. Any kind of balance exercises, because we know that changes, especially with that. But yeah, so lift heavy, plyometrics, hit like interval training, high intensity interval training, and get some balance in there. So we're not going to break our strong bones because we've been doing so many plyometrics.
Fantastic. And so it's certainly not a time to go easier on what you're doing. It's just being a little bit more choosy, and in some cases, potentially going harder. If you've never lifted heavy, and there certainly is, I think, still a bit of a stigma of, I don't want to build too much, I don't want to get bulky. That is not a risk at this point in this time of your life. Like, people who actually do try to bulk up have to work so hard. This is not an issue for us. We need to be pushing those muscles to make sure we don't lose that lean muscle mass, which is fantastic. And appreciate that perspective of not just getting on the treadmill for an hour at a time and wondering why the belly fat isn't going away.
Yeah.
Right. Mm-hmm. So let's talk about, as you mentioned it a little bit about pelvic floor, let's talk about specifically what happens in the pelvic floor and the changes there as we get into this and move through this phase of life.
All right, so I have my model. This is a pelvis, and I'm sorry about the lighting issues that I'm having right now, so hopefully everyone can see this. So with our pelvic floors, first of all, we can see the bony pelvis. It's actually pretty locked in and stable, really big fat bones here, really thick. So big, stable place in our bodies. We have everything that you see in red here, basically. So we have all of these muscles in here. This is the outside and kind of what it looks like. And this is kind of what it looks like on the inside. So if we kind of look at the structure of these muscles, we have muscles that are external and are palpable, I guess, from the outside, but then we have deep muscles that kind of line the inside of the pelvic girdle as well. So with these muscles, I'm gonna put my model down now for a second. These muscles kind of work like a hammock, or I like to use the analogy of a trampoline. So they are responsible for being part of the inner core unit, and they keep our foundation strong in our bodies. They are responsible for housing the pelvic organs and providing support for those pelvic organs. They are also responsible for keeping us continent of urine, feces, and gas. Okay. Oh, there you go. That's a nice little, that's even better. That's a very small pelvis. Is that a pediatric pelvis? What's that? Anyway, so yeah, that would be more of a smaller person's pelvis. I think the one I showed you is a little bit more life size. But so these muscles are providing a huge supportive role for a lot of things that live and are housed inside the pelvic floor and are responsible for keeping us dry, essentially. So if we kind of think back to everything that I mentioned as far as changes on the musculoskeletal level, if we have stiffening of tendons, stiffening of ligaments, loss of lean muscle mass, loss of ability to generate power and maintain endurance, these are a group of muscles that are going to get impacted by those changes also. Now, just to be clear, there are loads of reasons why pelvic floor dysfunction can take place. This is not just because we've taken away estrogen. There are plenty of other reasons. Childbirth, surgery, you could have been a trampoline artist or something, an athlete, lots of different reasons, right? So there's various reasons why these dysfunctions can take place. And if you're already kind of experiencing certain things, but it's kind of just like lingering underneath the surface, it's not uncommon for a lot of individuals to all of a sudden start to notice an increase in those symptoms as they kind of embark on that perimenopause and definitely into those menopausal years. So the things that we may start to experience are definitely incontinence is a big one that starts to happen for a lot of individuals. Or if it was happening a little bit before, all of a sudden the frequency of it is starting to happen much more frequently, to a point where now they actually want to do something to intervene, and it's impacting quality of life and all these types of things. Prolapse, pelvic organ prolapse is also another symptom and outcome of pelvic floor dysfunction that already could have been lingering underneath the surface beforehand. But then again, once we take away the elasticity and the supportive role that the pelvis is actually playing, or diminishing the ability to perform those roles, not taking it away completely, of course, but this can start to cause some protrusion of some of the organs into that pelvic space. So these are the types of symptoms that we might start to see. So basically anything that would be a pelvic floor dysfunction, even urgency and frequency issues, these are issues that can come about. We already talked about constipation. That's also an issue that can also come about as well. But just to be clear, that if you are having these symptoms, estrogen depletion is not the only reason why. There's usually a collective timeline of insults that the pelvic floor has to endure over the course of a lifetime. And certainly estrogen is only going to make those challenges much more apparent. So if you are noticing some changes, and if it's really significantly impactful to your life, we really, really highly recommend that you go to see somebody who is specifically trained to do an assessment that is individualized to you. Dr. Google is not going to do it for you. You really need to talk to somebody who's going to do a very specific assessment to your specific needs and design a program that will accommodate your specific symptoms and is very individualized to you.
Thanks, Uma. And, I think that point about making sure people understand what you're going through when you're looking for any treatment recommendations, any guidance, as you're hearing already, there is a lot of things that generally we don't know about. We don't know about all of these other little things other than, hot flashes we hear about changes in our sex drive, or, different kinds of pelvic floor changes, what we'll go into. But all of these underlying things we don't hear about. And if we do, there's just not that common knowledge. So you want to be seeking out someone who's very aware of what's happening so that they can give you the appropriate recommendations. Going to a trainer that has no idea what happens during this time could put you at big risk for injury. And then you're going to give up, or you're going to be injured, and you're going to be very disheartened about your efforts to try to stay healthy, and you may give up when it was just really not the right recommendation from the beginning. So, let's dive a little bit more into those changes, other things that we might see in the genital area that could be bothersome, and again, get into a little bit of what we can do about it.
Mm-hmm. So both Uma and I really function, we see a lot of people for pelvic floor specific issues or pelvic related issues. So I think that I probably answer these questions, I don't know, 3 to 5 times every single day, easily. And you can feel free to Dr. Google this if you want, because if you're using these words, then it's probably okay to look it up. But so especially something called the genitourinary syndrome of menopause, or sometimes they shorten it for GUSM. So we used to call it vulvovaginal atrophy, but I think people felt that the idea of us having these shriveling up vaginas is not or vulvar areas in general is not a very nice image, and it shouldn't be, because there are things we can do again. So, but this, first of all, we didn't mention this. I didn't mention it before. Generally, the average age that somebody becomes menopausal in North America is about 51. Now, I see women all the time that are in their later 50s, 58, 59. They're still getting regular periods. They might be having some symptoms, and they can't wait for this change to happen. So we just didn't mention that. So I just wanted that was my bad, just to go through that. But some other symptoms that people may notice, and people can even notice these changes as well before they lose their actual period. Although generally in my experience, I'm seeing it, when people are menopausal, it's kind of like when your tissue in your vulvar area is lacking estrogen, some of these changes kind of can happen, a few years after, I would say. So some of the changes would be definitely in 60 to 80% of women, people will notice like there's a dryness, there's a loss of lubrication, there's a thinness. So estrogen in our vulvar and vaginal tissues really provides this robustness for the tissue. It kind of, in the actual tissue itself, it provides this really, really thick bed of beautiful vasculature, little tiny blood vessels that kind of create a fluid exchange and keep everything plump and supportive. So your tissues just become thinner and less robust and less supportive. They become drier. Again, you have that lack of lubrication. We know also that with a decline in estrogen, specifically in our vagina, we have changes in our pH. So changes in your pH really, really can affect that we always need this beautiful synergy and balance of yeast and bacteria. So a lot of women will notice suddenly they've never been prone to urinary tract infections their entire life. And all of a sudden they're getting these multiple urinary tract infections. So a lot of that is just because that pH balance has changed. You have thinner tissue that's, especially if you're sexually active and you're not taking care of your tissue, it's more prone to little micro tears and trauma. So it's an entryway to pathogens. So you can have, tissue irritation and infections that way. And it's just you overall get a less compliant, vaginal area. So, a lot of people they'll go for a pap smear. And if they're not sexually active, they'll go for a pap smear. And all of a sudden they're like, what happened? That was so painful. I don't even know if the doctor did that properly, but I'm always like, how old are you? And when is the last time you got a pap smear? And sure enough, I'll look at their tissues and I'm like, their tissues they've lost that beautiful pink, like robust color. They're more gray, like you may notice color changes. So that's what we know happens, in that area. But there's tons of stuff you can do. So two things first, what easily you can do is there's over the counter, you'll see there's vaginal moisturizer. So I kind of laugh because we're kind of conditioned in our society that as we're aging, we moisturize everything else, except for the thing we really know is changing with that lack of estrogen. That we forget about. No one talks about it. We don't moisturize it. Moisturize your vulvovaginal tissues. And the best moisturizers generally will have something called hyaluronic acid in them. So hyaluronic acid, again, it's on all the expensive, eye creams and night creams. And so it's the same thing. It really sucks in fluid. So that is what hyaluronic acid, it's not an acid that burns you. It's not that kind of acid. It kind of attracts a huge amount of fluid or water into that area. So it kind of like plumps everything up again. So you can get those over the counter. They are non-hormonal and very, very easily accessible. So that is moisturizer. If you are sexually active or in any way doing anything with any penetration, you really want to make sure you are protecting your tissues by adding a lubricant. So that's what a lot of people get mixed up, because moisturizer is not a lubricant. Like moisturizer I'm putting on my face is going to soak into my tissues. Lubricant is going to allow me to glide things on top of a tissue. So if any kind of penetrative activity, that's where you really want a lubricant. So it's, there's water-based lubricants, there's silicone lubricants, it depends. That's a whole other discussion what one is more appropriate. A lot of people prefer water-based lubricants. They can tend to dry out, but you can rehydrate them if you want to add some more water, funny enough. But so there's moisturizer, there's lubricants, and then there's local vaginal estrogens. So this is something you need a prescription for, and you need to talk to a doctor about, but you can actually have local vaginal estrogens, which don't really overall change we call it your serum estrogen level. Like, so if somebody would take a blood test to see how much estrogen is in your body, with the local estrogen you only are putting in your vagina. So often that is not hormone replacement therapy, or now we're calling it hormone therapy. So it's called local estrogen. So often people are having phenomenal success with that. And that's definitely something, there's a whole bunch of different ones. They come in tablets and creams and rings. And, if that is a problem, easily talk to your family doctor. Most family doctors who aren't even very menopause aware, this has been around forever. So, people are extremely successful. There's a lot of talk right now about if they're safe for people who've had a previous history of breast cancer, all of these things. But I really encourage you to talk to your doctor about that, because these are things that are discussed a lot. So definitely moisturize, use lubricant when you need to. And then if you want to, talk to them about getting some estrogen, or another newer one it's called DHEA. And that's same thing, putting DHEA vaginally. Amazing also. So you don't have to suffer through these. Like it's not the end of your sex life. And in the end of having you're having these recurrent UTIs. And the other thing, which I forgot to mention also, is it increases urinary urgency. A lot of people, it's almost like the first thing they should do. If a woman is like, I'm 56 and all of a sudden I cannot make it to the bathroom on time. Like I am struggling. When I got to go now. That's what urinary urgency means. It's this overwhelming urge to pee. As it hits you. If you weren't there 20 seconds ago, you're peeing in your pants. Estrogen, because the receptors in your bladder are very, very estrogen sensitive. They love estrogen. So with that decline in estrogen, the sensitivity goes a little bit wonky. So those are the changes.
So much information and almost overwhelming. One, I think, to hear that there's actually a lot of things that can be helpful. I think it can be embarrassing. Let's be honest. You is this normal, and do you talk about it, and how do you bring it up? So thank you for just being really upfront about it, and trust a physio to describe it as beautiful vascularity. It's not how most people would think about it, but I love it. I can visualize it just with your words. We really don't have a ton of time. There's so much, and you can tell that these ladies are extremely knowledgeable and they could each talk for hours on end about the things that they've seen and how to help, etc. But let's really think about, and if you could each kind of summarize really what are the key things that you're hoping that people can take away from this session, and what you hope that message will be.
Should I go first?
Sure, that'd be great, Uma.
So I think one of the takeaways is that if you are starting to feel different symptoms and you're not really sure what's going on, you're not crazy. It's definitely something, and there is help. So you should probably go and seek out a healthcare professional who is knowledgeable and who can provide you some guidance and maybe an explanation also to what might be going on. And if you don't find that person, sometimes we have to be our own healthcare advocate. So shop around, keep looking for that person who's going to be a good fit for you, who is going to listen to you, who's going to be open to various options and not shut you down when you start asking about different things that maybe you've heard about or read about. So you really want to find someone who's a really good fit, because not everybody necessarily feels the same way about everything, and not everybody necessarily has the same outlook on things that you might. And if you really feel like someone's just kind of waving you off and saying, oh yeah, that's not a big deal, it's totally normal, and you think it's not good enough, find someone else, right? It's your health, it's your healthcare. And where it's a consumer's market, just like anything else. So keep looking until you find a good fit.
Yeah, that's a good one. And then what the other thing I'd want to say is also kind of on the flip side of that is, somebody had put in the chat, don't blame everything on menopause also, because it's so all encompassing. If you're feeling something weird, you still want to rule out that nothing big is nothing sinister or nothing dangerous is happening. I mean, you're still a complete human that had the same risk factors before. I mean, and maybe some have increased and some have decreased, but you still have to make sure all those things, if you're feeling weird things in your chest, yes, heart palpitations can be, maybe some people feel that commonly in menopause, but you still want to get checked out and make sure it's nothing. And as long as you've had a really good, thorough screen and we can be like, okay, it's nothing. Yes, then maybe it is menopause. We know that's a common symptom of menopause, but I would still want to get everything checked out to make sure that I'm safe. Because I don't let everything, it's an odd time where there's tons of symptoms and you just want to make sure they're not being discounted and your health isn't being discounted. So that was, that's a big one.
Just add one more thing. I think that as a society, we just have to start talking, right? Like we women need to look out for each other. Don't be embarrassed about talking about these issues to your mom, your friends, your sister, your cousins. I think the more that we open up these lines of discussion and we start to talk about these issues, the easier it's going to be for us all to, like we're all going to go through it, right? It's kind of like the same as death and taxes, menopause for women. It's all happening. It's going to happen to all of us eventually. So, let's just talk about it,
Mm-hmm. Absolutely.
And, Uma, you said, and I think we're hearing now, this process is normal. As Alana said, there is no post-menopause. If we all get old enough, we will go through menopause, but it's going to be an individual journey. And what that journey feels like for you is going to be different for the next person, but please talk about it. Please share it with younger people because, again, people start this in their early 30s and they have no idea how impactful what they do then can impact what's happening in their 50s and 60s. So I think those things are important. They're normal, but it doesn't mean there isn't anything you can do about it. I think for me, that's a really important message that normal or not, there is a lot out there that can be done and can help and can minimize issues and still allow you to live your best life and, not to think like, oh my gosh, once you hit this time, it is downhill slide from there. We certainly are being very encouraging and letting you know that's not the case. There's so many things that you can do. And we wanted to put up if there's other things that you have, or certainly those individual questions and situations that you're looking for more information about, or you feel like you may need some in-person type services, there is ways to get a hold of us: Facebook, Instagram, Twitter, LinkedIn, all of those things we're on. And then of course the referrals or the phone number, or take a visit to our website. There is a ton of information. And I think as information grows, again, Dr. Google can be confusing. People put information up that don't necessarily know what they're talking about. But Uma said it, if you're not happy, keep looking. There are people that can really help you dive into these things. You know your body best. And if you feel like there's something changing, then there's something changing. Dig into it, make sure you understand it, make sure you get to the bottom of it. And if there's things that you want to change in your lifestyle to make those differences, then we really encourage you to do so. And we'd like to walk with you through this time and make it as enjoyable as possible and still allow you to thrive and continue to have an amazing life as you go through this. Menopause, perimenopause, this is not, a doom and gloom story. It's a, what do I need to know and how can I make it a great story and make sure that I'm doing everything that I can to take control. Self-care is huge in this time of life, and it can be tough. Like there's lots of us now who have aging parents and teenage kids. Like we are definitely in that sandwich stage, but you must make sure you squeeze out time and carve out time to make sure you're taking care of yourself so you can take care of all of the other people that depend on you for doing those things.
And one more thing, I think we just wanted to, one of the really good evidence-based where I can feel comfortable sending people to is it's called the North American Menopause Society. And so, or NAMS, N-A-M-S. So they have a lot of really good, they have great patient, lay people resources and physician resources. And they have some, they have a certification that some physicians can get to be certified, like that they've done extra kind of training in menopause. So it's just a great resource where I can easily feel happy. Like I always recommend that because I know people are getting good evidence-based information and not la la land. Like That's the problem, especially in women's health nowadays. Everyone is trying to get on a bandwagon and make a buck. And it's just, it makes me crazy. So just make sure you're getting good information and not, when you're going to somebody who's, trying to charge you $5,000 for all these tests and supplements, you have to look at like, am I just going to be a forever patient of yours paying you $5,000 a year? Because I don't want that. I should be in rehabilitation. I'm not trying to make lifetime patients. So that's a big thing.
Yeah, and that, I think that's great. That North American Menopause Society, is that what it's called?
Yeah.
Again, a good resource that we can go and check out. And, we really lean towards the medical system and our physicians, but please don't think that each physician knows everything about this. This really is an area of specialty, and look and find folks that are passionate about this. Certainly people like Alana and Uma who have a passion and just dig deep. They are educating the physicians of the world, and the people that we lean to don't always have that that expertise that we might think they do by innate nature. So dig in. Really, we want to encourage you to take care of yourselves and find ways to make the most of this time of life and not wish it away, because every day is a blessing, and we want you to really be able to embrace it. So we're kind of coming up to the top of the hour here and needing to wind up. Just wondering again if there's any parting words or anything else that you ladies have on your mind. We're still busy answering in the chat. Thank you so much, folks, for typing those questions in, and if they're very individual, we do apologize. We can't answer them extremely specifically, but for sure reach out if we weren't able to answer them completely. But Uma and Alana, anything final that you can share?
Not unless we're going to go down a whole big other rabbit hole. Right?
But
No, I think it's.
If we have a few minutes, maybe we can kind of look through the chat and see if we can address maybe one or two questions possibly. I'm just kind of looking in here. I think someone had asked about moisturizers.
I think I answered that. Somebody asked, is it NASS? It's NAMS. So North American Menopause Society. Let's type it in anyway. But if you just Google that, that's a really great one. Anyway, okay. And there's the Menopause Manifesto. That's Jen Gunter, Dr. Jen Gunter. That's a phenomenal book. If you haven't, she's funny, and that's a fantastic book, and actually will make you a little bit upset about, how menopause has been totally disregarded. But I think honestly, it's disregarded because it is hard to study. But now finally, I think we're like, well, too bad that it's hard. We got to study it. So that's where we're at. It's being done. So that's great. Yeah. Okay.
And I am sure as time goes on, like all research, we are going to find out more and more things about menopause, about how it affects our body and the things that we can do. So I would say it's really on the leading edge of research, and because as women, we're not sitting back anymore and just saying, oh, I guess I'm just going to let this happen to me. We're battling back and making sure that we can do everything we can. So, I feel like there's going to be lots of research, and, Alana, Uma, do you see this? There's still there's just a lot of research continuing to come forward as we go forth.
Yeah.
Yeah.
Okay. Awesome. Oh,
Lovely.
That was a good one. Our Kegel floor, pelvic floor exercises. I hate using that word Kegels because I don't really know what it means. Just some guy's name. But so, yeah, they just actually did do a study that a lot of the stuff I was talking about, the genitourinary syndrome of menopause, and that elasticity and thinness can actually be improved by making sure you're getting a contraction and a relaxation of your pelvic floor, again, to get the beautiful vascularity, like the muscles, the blood pumping back into that tissues. But many people do not know what they're doing, and it's not just a matter of just do some Kegels, or else we probably wouldn't have to exist as therapists with waiting lists. So I do recommend, if you don't know if you are doing pelvic floor contractions properly and you aren't getting a full contraction and relaxation, please go see somebody. It's so easy to have a quick check. So that's another thing.
Fantastic.
Okay.
And remember, we will be sending out a copy of this recording as well as a summary in a couple of weeks to all of the participants. Thank you again for sharing some of your precious time tonight, and we hope that we do continue to offer these types of educational webinars for people that we can call in from anywhere and sit in the comfort of our own home and still continue to learn. A big thank you to both Uma and Alana. We really appreciate you sharing your expertise to make our lives better on a day-to-day basis. So thank you so much for sharing your evenings, and take care, everybody, and please go well. Bye-bye.
Bye.
Bye.